only.
Right. Let me just thank Dr. Somia and her team for inviting me. It's a pleasure and honor to be here talking among such esteemed faculty. I'm from Malaysia and I'm an endocrinologist, perhaps important to remind everybody, similar to what you've just heard from the earlier speakers. The issue around the cardiovascular outcome trials have superseded everything else. And I keep hearing, and I suppose it's a challenge from my cardiology colleagues who says, SGLT2 is a cardiac drug, and the nephrologists say it's a nephro drug. And then we poor endocrinologists who first found the drug are fighting for a position. Okay, and to actually just remind everybody, apart from the exciting data on glucose control, that we must, with cardiovascular protection, that we must still hold true to the fundamental management for our patients with type 2 diabetes, which is improving glucose control. So these are my disclosures, and here is just to set the scene. You guys are familiar, you manage patients with diabetes, you are very similar to what I see in Malaysia as well, which is we have a large population of people with type 2 diabetes, and they are also diabetic from a younger age. So this population global study shows that in fact, 1 in 10 adults are diabetic, and unfortunately, half of them are coming from the Asia-Pacific region. Western Pacific, there you have it, and then Southeast Asia as well. Accounts for about 50% of the global burden. So you and I are managing a lot of problems in patients with diabetes. So let's just consider. I would like to again reiterate endocrinology. Unfortunately, we have to still remember the A1C is important. We need to recognize the risks and benefits of both the approaches, right? As well as you heard from all the speakers already, that we need to individualize. It cannot be exactly the same for the patient A, B, C, D, E, F, G, as you just heard from Dr. Umar. They cannot be the same. Right? If you can picture yourself, right, that you have a patient who's young, who's slim, versus a patient who's big, and all this, you cannot be the same. So let's look at what is now the current trends of our recommendation for type 2 diabetes management that you and I subscribe to, right? We are living in very exciting times. I'm totally happy that I have so many options. You've heard from Professor Amir about SGLT2. Now we're talking about how to choose this one, that one, or another one, right? And we are so lucky to have all that, right? These, as you've heard from Dr. Umar, are the pillars of the management of a person with type 2 diabetes. And I like this, which we saw about the end of 2022, not too long ago, from the ADA ESD, that this is the framework. It's sort of like a circle. No single pillar outshines the next one. So we have to remember the glucose option that now we have added on, that you must try and get the patients to better weight. And on top of that, cardiovascular risk management, again, this is something that you know, you are familiar with. And of course, the exciting results that we can have drugs that will give us cardiovascular, renal protection beyond what they do on top of what they actually do normally. Okay? So these pillars in a circle, no one pillar says, I'm more important than the other one. So what are the benefits of looking at the A1C, at targeting the A1C and getting them to control? First, let's look at epidemiology. We cannot forget epidemiology, right? This is natural, what we see if we don't do and do not do anything to these patients. Here is an observational prospective cohort study from the UK, large number of patients, and the adjusted rates for myocardial infarction. And on this axis is the A1C. And you will readily recognize the higher the A1C, the higher the risk of myocardial infarction. And unfortunately, if you are a man, you have a much higher risk than a woman. Okay? The higher the A1C, naturally in prospective observation, the higher the complication rates that we see. And in this study, they were able to recognize that for every 1% increase in A1C, that you will have an increased myocardial infarction by 18%. Next, from the good old UKPDS, here is intervention. The UKPDS shows that if you intervene and reduce A1C, and the recognized statistical analysis, for every 1% reduction, you know this. I do not need to spell it out, that you will be able to see every single complication that you and I recognize as a diabetic complication will be successfully reduced. The effect and impact of glucose control. And those of us who have lived in the last decade, so excited about the cardiovascular outcome trials. We shorten it, abbreviate it to the CVOT, right? And they, in this meta-analysis by Professor Now, again, you have seen this, to show that the difference and the gap between the placebo arm and the active treatment arm, the bigger the gap, the better the A1C reduction in the actively treated recruits in these studies. The A1C reduction had an influence on the MACE outcomes. And you can see in the blue dots belong to the SGLT2 trials, cardiovascular outcome trials. In the red dots belong to the GLP-1RA. Again, recognized by all of us, including Dr. Uma, who just spoke here, right? That the GLP-1s are the most potent glucose-lowering drugs that we have currently. That if you have a bigger separation in the A1C between the active treatment arm versus the placebo arm, that the A1C difference in these trials, cardiovascular outcome trials, influenced MACE improvement and benefit. So even in these cardiovascular outcome trials, A1C improvement does have an influence on the MACE benefit that we saw. I'm just going to tweak two studies out just to show that the individual studies themselves were able to analyze their own data and come up with a similar result. In the leader using liraglutide, you can see that 40% of the influence of the MACE outcomes was shown from improvement in A1C. And in the rewind trial, with the dulaglutide as the active agent, about 36% of the improvement and the benefit of lowering MACE outcomes was shown to be cause, or rather a result, of the improved A1C reduction. So even in the cardiovascular outcome trials, A1C matters. Going back again, should we intervene? All right, then the question, doctor, can I do it now? Can I do it 10 years from now? Whatever, right? And this is an observational study to show from the US that in fact, if you intervene late, you will lose time. This is the microvascular complication according to categories of A1C. The higher the category, you see the microvascular complications are higher. So if this is individuals in that cohort observation is within 1 year of recognizing diagnosis of diabetes, that the highest A1C of 9 is increased risk by twofold. But if you actually delay that by about only 7 years, you have a 6-fold higher risk of having microvascular complications compared to somebody whom you have intervened earlier. Have we seen it in intervention trials? The answer is yes. We've seen a similar phenomenon. And this is statistical analysis from the UKPDS trial. This UKPDS, again, you know this study very well. I don't need to explain it to you. Newly diagnosed individuals with type 2 diabetes from the UK. And they were able to analyze this data and show that if they reduced A1C by 1%, but delayed it by 10 years, you reduce mortality by 2.7%. Not too bad, some improvement, some benefit, but if you actually did it from the time diagnosis of diabetes was made, you reduced mortality by a massive 18.8%. Look at how much time you have lost if you actually delayed diagnosis, delayed intervention. So again, very, very important to do it early. This is a meta-analysis of the glucose trials that all of us are familiar with, ACCORD, Advanced, UKPDS, VADT, right? Large number of participants, and they were able to have a follow-up of at least 5 years, and then you will recognize that the risk of reducing kidney events was 0.8, and then retinopathy by 0.87. So very important data to reinforce our management that improving glucose control, A1C being the surrogate marker that we are using, matters. It will reduce all the complications that we are looking for. And of course, let me drill down to one specific study, and I'm very proud to be part of this study that was done in Asia. We actually were able to contribute 40% of the 11,000 individuals in that study, 4 countries, including India, China, Malaysia, and Philippines. And you will see here the improvement of A1C by about a separation of less than 1% was able to improve renal outcomes. And again, you've heard from Dr. Umar, and similarly in Malaysia, we see a huge number of patients with renal complications from poorly controlled diabetes. And this is something, again, that we should hold true, that if we actually improve, intensify glucose control, we can reduce that trajectory, as you've heard, again, that loss of renal function that we hope to be able to prevent. And of course, the legacy effect. You think to yourself, Dr. Chan, if I treat this patient now, do I see a benefit? Is there an investment for the future for this person's health? And the answer is absolutely yes. You knew that. The UKPDS showed us already quite a while ago, the post-trial monitoring, that it was worthwhile. But then about 2 years ago, they were able to show us the 44-year follow-up study. And I think you would have seen the data as well. Let me just show you again in graphic form that in the first 10 years of intensive improvement of glucose control in the UKPDS, significant improvement of microvascular benefit, right? Then another 20 years later, you see the improvement in all the parameters that they were looking at, and 44 years later, significant impact. So there is a legacy. Invest in the bank, give more money, then at the end of the day, not bankrupt. Right? So it's really very important. It's worthwhile that it will continue to give you benefits years later. And of course, I think all of you have been so well inundated, saturated with the cardiovascular outcome trials that you can even repeat it to me in your sleep, right? I'm not going to talk about it. I would just say, think about it. Who were the patients who were involved in these trials? They were all patients either already established cardiovascular disease or were high risk of developing cardiovascular disease. They are not the run-of-the-mill patient that you see every day. Maybe some of you are in tertiary care, maybe you see more of them. But certainly not every single person has cardiovascular disease or chronic kidney disease. And here, just to again show from the population of patients with type 2 diabetes, about 60% did not have cardiovascular disease, did not have renal disease, and therefore they may not necessarily require the SGLT2. All the more not necessary to get the GLP-1, which is going to bankrupt many people, right? I just heard from you, just as expensive here as in Malaysia. I think I tell my patient, do you want to go on this? First of all, it's an injection. Do you want to go on this? Then you tell them the cost, and they fall off their chair, right? So let's talk about how do we marry the two results that I have just talked about. I'm not just saying I don't believe in the cardiovascular outcome trials. I'm totally embracing the data, and in fact, I'm so thrilled that I can offer these patients something to change the trajectory of the renal and cardiovascular disease. But let me just go back down to the ground. This is a patient that I saw about a couple of months ago. No, not this, a different patient, okay? This is a patient that I found out a couple of years ago. 2021, she was only 49 years old. She had diabetes for about 3 years, big lady as usual. She was admitted to the hospital with stage 4 COVID. I think I'm so excited to be here because this is the first time we've been able to travel without much problems. Guess what she's doing today? What do you think she's doing today? What do you think? Tell me. What do you guess that she's doing today? Is she having tea with her children? Is she cooking her lunch for her children? What do you think she's doing today? She's dead. Okay? So she's one of the statistics of patients who were poorly controlled, who contracts an infection, and COVID is not the only thing that will do this, that they will succumb. They will have a higher mortality, morbidity, if their glucose is not controlled and they have an infection. Okay? So again, well before she gets a heart attack, well before she gets renal dialysis, she's already no longer with us. What is important here? It's important to recognize, right, that in fact, we should get in there early. We should do all the measures that you've heard. You know what to do, lifestyle, all these other things, but give her something will be effective at improving her glucose control so that they will not have morbidity and mortality from infections that you and I treat day in, day out. Nowadays, in Malaysia, we got plenty of patients with dengue, plenty of patients with influenza A, right? Many of them have diabetes. And this is real-life data from your own local, and you have just finished Ramadan, similar to what I've seen in Malaysia. And this is data to show that you can actually fast safely using sulfonylurea like glycoside without causing a lot of morbidity. This is from the Dar Ramadan, the Pakistan cohort. 220 patients were involved in this study done by your local professors and KOLs, and they were able to show that they were able to do this safely. Patients like I recognize these patients as well in my practice on multiple oral glucose lowering therapy. And then they were able to do it safely throughout the entire month of Ramadan with very low risk of hypoglycemia, something that everybody is terrified about, especially when you have a very prolonged time that you cannot eat. On top of that, the data from the Pakistan study, right, shows here, maybe if I can show you, that at the end of 1 month of fasting, the A1C improved, larger percentage had better glucose A1C. They had lower rates of high A1Cs, and then they were able to calculate improvement of A1C by 0.4%, and on top of that, reduction of weight. Wow, not bad, right? So I think I tell my patients, not really seriously joking, you should fast more often. So in summary, thank you, Dr. Somia, and all the professors for inviting me to come and share my practice and my thoughts on the importance of glucose control. And I've shown you all the data and the evidence that hyperglycemia is the root cause of the complications. And therefore, we should go for the root cause. We should do it early, because it will reduce complications. It will give us the legacy effect that we've not seen with the cardiovascular outcome trials yet. And of course, where do I sit and where do I see the cardiovascular outcome trials? I embrace it. I add it on to a balanced control. I tell my patients, good for you. I have so many options that I can do or give you so that you can improve your quality of life as well as quantity of life. And therefore, balance the potential of the realities of whether or not you can afford these medications and some patients who may or may not really require them in the first place. With that, thank you very much for your attention.